Well, thank you. That was excellent, Serena. I really appreciate it. Serena did a terrific job of showing us the science behind DPYD. But what about the patients? What does this mean for patient? What does this mean for family member? And Karen Merritt has traveled all the way from Seattle, Washington, to share her story and her family's story so that we can really understand exactly what all of this data means in an individual patient situation. Karen is the founder of Advocates for Universal DPYD Testing, and she is the recipient of the first CAGLA National Advocacy Award as well, which we presented at our reception just 2 nights ago. So without further ado, I'm going to let Karen tell her story and that of her mother.
Good morning. Thank you to CAGLA for having me here to share this story, and I appreciate Serena sharing all of the details, as I am not a scientist, former elementary school teacher, and co-founder of Advocates for Universal DPYD testing. I know it's a mouthful. I wanted to talk to you about why we need to test for DPD deficiency. This is my why. This is my mom, Linda. She was diagnosed with stage 3 anal cancer at the age of 73. She was otherwise healthy and enjoying retirement, her family, friends, and taking on new activities at 73. Her treatment plan after this routine colonoscopy found her cancer was 5-FU chemotherapy. She was said it was going to be fairly well tolerated. And the worst thing about her treatment, she said, was having to spend the hot summer in Phoenix, Arizona, which they usually didn't stay there during the summer. So this is what happened to her. Her single 5-FU infusion started on a Monday. By Friday, having been a registered nurse, she knew she was dehydrated. She went to the emergency room after talking with her oncologist and got hydration. She was scheduled for hydration on the following Monday, but they decided that she needed to go because she was having continual diarrhea. And her mouth sores and her throat were hurting her, as well as her bottom. So she gets her hydration on a Friday, goes home. Still, the mucositis, the sores in her mouth, she's not able to eat or drink. She gets up to go to the bathroom in the middle of the night, and she collapses. My stepdad calls 911. She goes to the hospital on June 19th, and the oncologist on call from her practice says it wasn't possible to know that this would be her reaction before treatment began. And what we know now is that is not true. She could have been tested for DPD deficiency. She should have been informed about this risk, and things could be different. Now, when she went to the ER 5 days after not even starting her treatment, this would have been the time to diagnose severe toxicity. At the time, Vistigard was not approved, and I call this the supposed antidote because the time window to give it to a patient is so small, 96 hours after the end of your infusion or your last dose. So that drug was not approved at the time, but also ER doctors, I don't know if they are not prepared to diagnose the toxicity from 5-FU. She should have been seen by her oncologist when she called and was explaining the continual diarrhea. She spent 2 weeks in ICU with round-the-clock care, and each morning we waited for her white blood cell count numbers that were 0.01. And they said, once those start going up, we'll know she's going to turn the corner. She's going to be in the hospital for 2 weeks is what they told us. She's going to be very sick. Well, she did not come home. She died on July 2nd, 2014. On her death certificate, her cause of death is listed as cardiac arrest. We should have fought in hindsight to get this changed. Toxicity to 5-FU chemotherapy was listed as the 4th cause. But if we had changed it to be number 1, this could have been reported as an adverse drug event. I have to think that there are other patients, similar reaction, and this is going unreported, so the FDA is not aware that this is a crisis. So other families and we have come together to form a nonprofit so that we can raise this awareness. How often does this toxicity and death happen? A risk that's considered rare and acceptable in the NCCN and ASCO treatment guidelines. Rare and acceptable, as you heard from Serena earlier, 3 to 8% have a DPYD variant. This is like 1 in 20. This is not rare, 5%. And variant carriers have a severe chance of severe toxicity and a 3% chance of death. This death from toxicity to 5-FU is akin to torture. You are burning from the inside out. My mom was one sore from her mouth all the way down her intestinal tract. When she was in the hospital and they were having to suction out the mucus so that she could swallow and breathe, they would basically be suctioning off the scabs to the sores in her body, and then she would be bleeding. It was not a pleasant sight for a loved one to watch, and the nurses even there were quite struck. Most people are unaware of this deficiency until it's too late. Not testing a patient before, and if you wait until they have toxicity and then test, in cases like my mom and other families in my nonprofit, 1 dose was too much. There is no dose reducing after the patient has passed away. Pre-screening for DPD deficiency and dose adjustment reduces toxicity, saves lives, and it's cost-effective. To me, when I hear the word precision oncology with fluoropyrimidine, it's testing before treating, not testing after the first round. 5-FU and capecitabine are amazing chemotherapies for many, but for some, they are not. We have the knowledge and the testing is available. We're a data-driven society. We should be using this tool, and I applaud Oxner for being heroes. I know that oncologists, when they treat their patients, they know a person isn't just a number. This is my mom and our family. And we like to say Linda was so easy to live with and so hard to live without. She was really the glue that kept us together. After she died, we almost lost my stepdad too. The human cost of not testing has brought a bunch of families together, and we are going to advocate until standard of care in the United States is in the NCCN and ASCO guidelines. These are all loved ones that we've lost, and unfortunately, this group keeps growing. We created our nonprofit to hopefully reach patients also before they start their treatment, but what's been happening is we're getting calls from families when they're in crisis or they have lost a loved one. I want to tell you about a patient that we just met in January of this year, Emily. Emily had a successful Whipple surgery in December for stage 1 bile duct cancer. Emily is a researcher by nature. She learned about our website, and she had a community oncologist and a second opinion at an NCCN cancer center. She asked both of those oncologists for a DPYD test before starting capecitabine. And these oncologists, both of them told her, oh, we don't do that testing in the United States. Emily proceeded to show them the list on our website of the cancer centers that are testing. It took her a lot of fighting with them to finally get them to test her, and her results came back. She has a star 2A, most common variant. If she had been started on full dose chemotherapy, she doesn't think that she would be here. And for her family to tell us they are so thankful for us and feel like she is only here, that makes the losses that we've suffered at least meaning something. Is that we do not want other families to experience the loss that we have. Her community oncologist was frustrated that he was going to have to figure out how to dose reduce her after getting her results back. Our mission is to improve the standard of care for cancer patients undergoing fluoropyrimidine chemotherapy to include DPYD testing. These are some of our testing supporters, other nonprofits. DPYD testing in the United States. Well, the FDA revised the drug label warnings in 2016 after the first citizen petition by the president of our nonprofit, Ken Serpernot. The FDA safety labeling changes for capecitabine in December 2022 and for 5-FU also were as a result of a citizen petition, but also in conjunction with Project Renewal, where the FDA is updating older approved oncology drugs. The FDA and the AACR hosted a DPYD workshop January 16th, 2025. They brought together stakeholders, advocates from my group. There were pharmacists, NCCN representatives, and FDA. There were also other cancer centers that were there. We had hoped that after that meeting that the FDA would make a recommendation in the label to test before treating. The FDA tells us that there's not an FDA-approved test, so they can't recommend testing. And then for the NCCN that we've been petitioning them, they've been petitioned over the last 10 years 8 times, and they still have not made the guidelines safer by recommending pretreatment DPYD testing. And what we know is that we've heard the NCCN guidelines, that is what people are following. My stepdad and my older brother kept my mom's follow-up appointment on July 6th, 4 days after she passed away, to ask the doctor, why don't you pre-screen for this? And are you gonna start pre-screening in the future? She wasn't sure she was going to pre-screen in the future, and her response about why not pre-screening my mom was, I followed the NCCN guidelines. We have the capabilities to test like Oxner is doing, like Serena shared. We should be doing this. We need to be aligning our guidelines in the United States with our European counterparts, the UK. Canada just this month recommended pre-treatment DPYD testing. It came out from Health Canada. Canada also, I learned, has black box warnings on 5-FU and capecitabine. FIGHT CRC just added to their care sequences for oncologists to NGS testing and DPYD. So they're calling it out. This is going to change. These are leaders in testing. These are our superheroes. On the left side are institutions that have institution-wide testing. Oxner is on there. The institutions on the right are where one oncology practice is. So for instance, University of Michigan, all breast cancer patients are tested before capecitabine. These are truly early adopters, and we are excited with each new addition here. We would love to add others to this list, so if you are aware of other cancer centers, we would like to add them to our list. We really believe we're getting to, these are our innovators. We're getting to the early majority. We are reaching a tipping point, and it's better to be testing than not testing. How can you help? This is my call to action for all of you, and I loved what Dr. Jernigan said earlier. It's better to light a candle than to curse the darkness. So this is me asking you to light a candle. You know the risk, share this with others. After all, we're all going to be affected by cancer. We'll all know somebody, friend, or a family member. Oncologists, Request a DPYD test at your intake appointment if your cancer center doesn't already test. This is what the Veterans Administration does for all veterans. They added pretreatment, they added DPYD testing to their initial clinical intake. Hospital administrators, make it easier for your clinicians to order it. I think I've heard somebody say put it in the order set. Ochsner's done this, St. Elizabeth Healthcare, Dr. Daniel Flora there, he calls it the easy button. Pharmacists, urge your hospitals and institutions to implement DPYD testing. Levine Cancer Center's done this, Dana-Farber, they've had publications of their implementations. Also in the clinical pharmacology and therapeutics, there's a guide to DPYD implementation by Teresa Ho and team. Lab companies, I used to say include the CPIC recommended 4 variants and this other variant that affects African ancestry. But as of August 2024, the Association for Molecular Pathology, Tier 1, that Serena shared, Tier 1 is should have, Tier 2 would be like to have or good to have. And encourage insurance to cover tests. Many are already covering it. American Cancer Society Cancer Action Network is really hoping to push biomarker testing legislation in each state. Wonderful that CAGLA and CAGLA Cares has biomarker testing here. Unfortunately, I just heard that the biomarker bill in my state, Washington, is dead this year. A DPYD test for my mom would have cost in 2014 somewhere between $500 and $1,000. Now it's under $300 compared to the $500,000 ICU bill that my mom had or Medicare paid for, in addition to the loss of a life. So I urge you to test for DPD deficiency. Thank you.
We're going to ask a few questions of our panel, our presenters from today, and I'll also open it up to the audience in a few moments as well. I'm also going to ask Dr. El-Nashar to come up as well. And let me grab one more chair. Oh, thank you so much. Dr. El-Nashar is with OneOme. And OneOme is a company that provides pharmacogenomic testing. They're one of our CAGLA sponsors, and that includes, of course, DPYD testing. So actually, I'll start with you, Dr. El-Nashar. Obviously, the value of pharmacogenomics is being realized more and more every day. But can you tell us a little bit about how different hospitals and health systems and physicians around the country are integrating pharmacogenomics into their practice, inside oncology, maybe outside oncology, and how's it working and what's the impact?
Yeah, great question, Dr. Matrana. So I've been with OneOme for a little over 5 years. I'm a trained clinical pharmacist and I lead the medical affairs team at OneOme. And we are a spinoff of Mayo Clinic, and that is an excellent question because over the years I've seen it where physicians are, I would say at the beginning, 5 years ago, what is pharmacogenomics, or PGX for short? And now the question is, I've heard about PGX, my patients are coming to me asking about PGX, how do I implement this? How do I use this? And really the key question is determining where do you want to start in a hospital. So great example where Serena talked about today in terms of starting in the oncology space, for example. That could be one area, and then thinking about where do I scale? Where can I help my patients and have the most impact? And it is really, really important to think about, okay, when you're in the electronic medical record, where am I going to put the report? Am I going to put it in the allergy section and it's just in a report where it's going to probably be difficult to find? Or do I implement and put alerts that specific alerts when needed for really important drugs like 5-FU and determining, okay, can I go in and what do I do? What do I do when I have a variant? What exactly, if I'm a poor metabolizer, what is it that I need to do? And that really streamlines the process. And so I would say overall, number one, education, having a great team, as Dr. Matali talked about today, and Dr. Matrana. They did a great job. And Dr. Catherine Oliver, great team. They did a wonderful job in determining a population where it could help pharmacogenomics and creating an impact for patients and helping save lives.
Excellent. Thank you. Thank you so much. Serena, your job is critical to making sure patients get the right drug at the right time, at the right dose. Can you tell us a little bit about the job of the PGX pharmacist? What's your day look like? What training did you have to do to get to this position? And how do you integrate into the team?
Yeah, thank you. That's a fabulous question.
Yeah.
I think to really echo a lot of what Gada was talking about, what we do as pharmacogenomic pharmacists is really looking at the data, and from there, how do I put that into my electronic health record so that my clinicians who are using pharmacogenomics can actually understand what the information is and what they need to do based on the patient's results. So a lot of what we do is, looking at new studies that come out, different guideline recommendations, and if there is enough data to show that we need to either avoid a medication or change someone's dose based on their PGX results, we are able to integrate that directly into our EHR. So whenever I also consult patients and whenever I talk to them or my clinician groups, I say, if you order the PGX for someone and you go to order a medication, you don't even have to know that that patient had pharmacogenomics testing ordered. But if you order a medication that needs a dose reduction or needs to be avoided, our system will tell you. It'll pop up and say exactly what you need to do. And if you have questions, it'll give you the information to contact us and our team. So a lot of what we do is just building upon the really strong foundation that we have built at Ochsner. And I know we talked about this a little bit with the pre-cycle testing with DPYD. When an oncologist goes to order a regimen containing a fluoropyrimidine, it's just automatically ordered before patients ever start the chemotherapy. Yeah. So thank you.
Excellent. Thank you. Karen, the story you shared with us today was so moving and so impactful. You alluded to this a little bit already, but what do you think it's really going to take to implement universal testing for DPYD in the United States? Is it a black box warning? Is it NCCN guidelines? Is it the trial lawyers filing a class action lawsuit? What do you think is going to move the needle?
Well, I would hope it would be the NCCN guidelines or ASCO guidelines or a combination of the two. It would be a shame, and it is a shame that we have to wait sometimes for legal action. That takes a lot of time and money, and it's hard on the families. There are legal cases going on now, so it's kind of like a race. But when the FDA updated the safety labeling for capecitabine and 5-FU, it really pushed the burden from the patient having to know they were DPD deficient to the clinicians and the hospital. So now that they have to be informing the patient and discussing testing, it seems like Ochsner and the other cancer centers that are automatically doing testing like that is also the way to go. So it's a kind of a multi-pronged effort, I think.
Yeah, thank you. Dr. Norberg, you discussed the complexities around precision medicine, all these different tests. You've got a whole wall of boxes that you could pull from. What are the biggest challenges you face, and do you think just the whole industry faces in implementing precision medicine, making sure the patients get the right tests at the right time, and then making sure that the information gleaned from these tests are actually used in a clinical manner, appropriate clinical manner?
I mean, it's like I mentioned, it's integration and education.
Yeah.
And I will give a shout out to OneOhm because I learned about it the other day. We do other testing for behavioral health, and your colleague kind of educated me a lot, and I learned a lot in taking stuff back to our practice to initiate pre-test and then making sure it's in the EMR at an appropriate place. But I really think it's about education. I mean, like you said, talking to your providers, and it really falls on the patient to say, hey, I did this or I belong to this organization. And I mean, I know the physicians can't always do everything, but that is who's taking care of you.
Yeah.
And, you know, I mean, I don't have to tell them how to treat me for cancer, but I will if they don't pay attention. And that's the whole thing.
Excellent.
Everybody knows that in my work. So,
Dr. Young, as a molecular pathologist, what are your biggest challenges in order to make sure patients are getting the right test and translating what you're seeing in the lab to clinical to the clinic?
Well, I'm a pathologist. I would like people to call me diagnostician instead of pathologist. We use different technology to make a diagnosis. Finally, we make a diagnosis. But make a diagnosis not as easy as people think. Okay, multiple factors involved. Start from the patient, the first patient visit, the procedures, and after the procedure, it's a lot of things happen in the lab. Actually, I very like to show people outside the medical field my lab, our lab. Every time, even 5 minutes tour, they say, "Oh, so complicated." Okay, so then I told them, "All right, we're not allowed to make mistake." So this is very difficult. It's much more difficult than people think. So I think the communication is a key, at least in my practice, communication between me, my team, and my colleagues to the clinician, to the, of course, through the clinician to the patient, right? And including the communication between our department and the reference lab, because if anyone in this chain don't have sufficient information, that is the most important source of mistake. So that's why the biggest challenge of my daily life is phone call. Whenever I got a phone call or I try to make a phone call, sometimes it's very challenging. But fortunately, currently at Ochsner, we have a pretty easy communication chain between like the reference lab and the pathology department and the clinical department. So, but I just want to send this message and this information out. If you have any question or any concern about the pathology diagnosis or any type of lab testing, the best thing you can do is call your pathologist first. Okay, I'm not saying we know everything, but we know our limitation. We know our limitation. We don't know how to do something, we tell you we don't know how to do something, but we will find the resource for you to help you. But if you don't talk to us, sometimes waste time or money and the problem not solved.
Communications. It all comes down to communications. The point about the phone call is well taken, and we were discussing earlier, and no offense to younger people in the room, but our trainees, I find our trainees are terrified of talking on a telephone. They will text, they will chat, they will do everything, and they will stretch out a conversation for 45 minutes on a text that could have been a 2-minute phone call. I'm like, please, just talk on the phone with me.
Phone call is much easier, and a message is okay, but depends on how complicated the question is, right? Sometimes.
Yeah. And it used to be that when I called the hospital operator, I wait on hold forever, to get somebody. And now if I call the hospital operator, they come on immediately because nobody's calling and using hospital operator anymore. I think they're probably crickets in their office over there. But that said, Dr. Stagg, you have been treating patients in the community for a long time, and you have seen a lot of changes in oncology. You've really seen precision medicine kind of rise up. And you are a huge proponent of it in your practice. Where, given your perspective, where do you see precision medicine going, and what do you think the future of precision oncology looks like?
So right now, everybody gets HER2 testing, everybody gets PD-L1, IHC, everybody gets next generation, all the solid tumors, and I feel like you have to do that.
Yeah.
And then for the heme, the profiles are different, but the testing is similar. So you have to do that to treat people appropriately. And if you look, all these new drugs all have some mutation or some other, you can't treat people without that information. I resisted a little bit a long time ago, but now it's everyone, regardless, gets to testing, and it's only going to get better. You have all these little nuanced therapies and all these little things. It makes it hard to keep up with all, but it's better. Care is better,
Yeah, yeah,
and it's only going to continue to improve.
no doubt about it. No doubt about it. Any questions from the audience? Yes.
Isn't the organization educating the communities regarding those testings? Because sometimes, a lot of physicians, not education, nobody knows about it. They may be willing to even pay for it. Insurance is not covering it.
Well, I don't know of anybody doing that, but I'll tell you that in all of our tumor conferences, and we have a lot of them, it's always brought up and it's always asked, did you do next generation testing? Now, for some, like sarcomas, it's not that important most of the time, but sometimes it's extremely important. And I think that the medical community in general is adopting it in a blanket fashion. You have to do it for lung cancer. And we're extremely thankful that a lot of people like Tempus not only do the testing, but help you interpret the test and help you decide if there's clinical trials, and then they actually don't send the patients bills. So we're very fortunate in that regard, but I don't know anybody reaching out to patients.
I'm not aware of any either, but it's, yeah, sure.
I was just gonna, as we speak, my colleague, we're having an African American Family Day, community event in Shreveport. And a lot of the stuff we do, and I'm gonna do the same thing for all y'all's testing, we do educate the patients, and sometimes the patients come in with their flyers knowing more than their family practice person. So I do think it is a community-wide effort. Like I was at a great GYN session yesterday, and the stop of the endometrial cancer hashtag. So I texted the nurse practitioner I work with. I said, y'all need to put this out there so they can all, as a community, as a future patient, current patient, family member of a patient, they would know that. Because it takes a lot of people to really motivate to get things to happen.
Terrific. Other questions from the audience? Yes.
Wondering, why do you think DPYD testing hasn't been added to guidelines as of yet? Sounds like we've got, literature to support it. And so I'm just curious as to why there's such a hold on that.
The NCCN, and I mainly work with the colon, anal, and rectal cancers panel because my mom had anal cancer, and their response to us is that we don't want to reduce the efficacy. They're worried about overall survival and progression-free survival, and our response to them is, if you kill the patient by not testing them, there is no overall survival for that patient or progression-free. I think that with the continued advocacy and the outcry from patient organizations, with the cancer nonprofits that are also backing us now, with the leaders in testing like Ochsner and Duke and Dana-Farber, it's coming. We've been told that the NCCN is a very conservative, they take a long time. For something like this, if they were to change guidelines, care in the United States would change, and we would be aligned with all the other countries that are testing. So, thank you.
Go
I
ahead.
can add on to this too. Another thing with, data and DPYD, it is unethical to do a randomized control study, right? You can't give patients a dose that has a 77% chance of having a severe toxicity. We just simply can't do that here. What we are doing kind of, in response to NCCN's ask is we're working on a multi-site collaborative research study with the University of Michigan. And so really a lot of the leaders in DPYD testing, we have data, we have patients that we've treated with dose reductions. And so we are putting together all of our data to reach that statistical significance for the progression-free survival and overall survival that they're constantly asking us for. So we are working on it. We don't think that they should need it, but it is something that we're working on as leaders in testing.
I want to add one thing I didn't say also about pharmacogenomics, especially DPYD. It's a hereditary. right? My mom had DPD deficiency. I have DPD deficiency, star 13, rare variant. I got all of my biological children tested, and thankfully none of them have inherited it. But it's something that is not only helping your current patient, it's going to help their family as well.
I'd add to that too that what's really important is education and talking to, when patients go and talk to their physicians or pharmacists, they are bringing their attention to how this is really important. And the more physicians, the more pharmacists you have advocating about this, or the American Cancer Society Cancer Action Network with the biomarker bills and all the work and legislative work that they're doing, the more you'll see guidelines come around. Guidelines are the last to come around. It does take years, but there is evidence, as Serena went over today with DPYD testing, and which is why I encourage every physician, every pharmacist out there to speak up, to advocate for how they see this is really important with their patients and what they're seeing with their patients. Because without that, then there will be no change.
Yeah, and I think that's a terrific point. And, we think about how these guidelines get made. Each of these guidelines has a separate committee. Those committees meet. And like many committees, there may be one or two individuals that are a little bit more forceful or louder than others on the committee. And so, the bulk of the committee may come down to just a couple of people, and they may have some big biases, and things don't move along, not because the data's not there, but because of those individuals' biases. That brings up a good point, though, about making the testing accessible and affordable. Here in Louisiana, we're very fortunate because the laws that CAGLA has passed mandate that this coverage, that PGX testing be covered by insurance companies. But not all states have that. In fact, most don't. What is OneOme and companies like yours doing to make this testing more accessible to patients?
Yeah, absolutely. With OneOme specifically, we have a patient assistance program, and we really want to make this accessible for patients and to really advocate for the patients. Patients first is our mission, and really to help the patient have access to this maybe potentially even life-saving test. And especially in oncology, you need to know this information prior to testing, and there's no other way to knowing how to dose the medication without testing. It's not by how, with anything else. You need to know the genetic result to be able to make an educated dose adjustment. And in that regard, so that's what OneOme does. If you have any questions, physicians or patients, feel free to ask us. But another point, and I know I mentioned this, in terms of advocacy, we do a lot of advocacy national and statewide as well. So talking to your legislators and educating them about pharmacogenomics, because it makes a huge difference. Similar to what Dr. Matrana, you've done here in Louisiana. That is huge, especially with the biomarker bills. And being able to implement that into the bills, you have the payers then have minimal reason to say no to paying for the test. So there's evidence there. There's policies. The biomarker bills let us know if you want links to it for your respective states. There's 20 plus states where it's been approved already, and more. I mean, the American Cancer Society Cancer Action Network is doing a ton of work. We at OneOme also volunteer to work closely with them to make sure that we can provide this to patients and to bring that education forth to legislators as well.
Thank you for that. The job of the state legislator, as I have learned in doing my work with CAGLA, is a tough one. These guys are mostly lawyers or maybe some insurance salesmen, and they're asked to vote on things that are very complicated things involving healthcare, involving education, involving the oil industry, involving environment, so on and so forth, all maybe within the span of an hour. And they're not experts, and they rely on the people who come to them, their constituents, or often lobbyists that are paid for by industries to educate them. And this is the only information they have, and they have to go on it. So, we represent the cancer patient because God knows the insurance industry has their lobbyists there providing whatever information or misinformation that they want the legislators to have. So somebody has to stand up for the cancer patients, and that's what CAGLA does. That all said, any final questions from the audience? All right. How about for the panel? We'll close it out, and I want to ask you before we do that, one final piece of advice or one final take home that you'd like the audience to have before we close it out, and we'll just go down the line.
All right. So education, advocacy, and finding a team that will really be a champion. So similar to Dr. Matrana, Catherine, Serena, you all are a great example of what really makes it to have a positive change, and without a team to make it happen, at the end of the day, you're saving lives and you're helping these patients. So I would say education, educating your peers, educating the patients, and advocating with legislators. And yeah, so that would be my recommendation. I do want to add, by the way, insurance coverage is getting better. It has gotten better, especially with the biomarker bills.
Call me if you need it.
Call me if you need me. I love it.
I very much agree with that sentiment. I was going to say, consider getting involved in a molecular tumor board.
Yes.
I would say, as a clinician, understand and share your patient stories. We can know all the data in the world, but when you talk to these key policyholders, legislators, and you're working for advocacy, what they really care about is the patient experience. And all of the progress that you've made towards the FDA and NCCN up to now would not happen without your advocacy. So, that's why I do what I do, and I want all clinicians. I know we get kind of, into the data as I do, but really the reason for that data is our patient stories.
I agree. Patient advocacy is big. I mean, you got to care for the people you take care of, and that's really the bad. Nobody cares how many kits I have in the clinic. They do care that the difference was made, that they're being taken care of appropriately.
And I would encourage you to share and talk to all oncologists that you know and encourage them to test patients for DPD deficiency before fluoropyrimidine chemotherapy. When I talk to pharmacists or pathologists, they're like, oh yeah. But with oncologists, sometimes it takes a little bit, maybe it's a change of, it's something different. They haven't done this before. They've just prescribed 5-FU or capecitabine, but to think ahead and to test early on so that you have the data to make the best decision and share with your patient so that they can make the best decision for their care.
Thank you all. This was tremendous. Now let's have lunch.